Hand aging is characterized by visible extensor tendons as well as a visible local dorsal venous network as the skin becomes thinner and loses its elasticity. The technique of autologous fat grafting is particularly adapted to this indication of rejuvenation of the dorsal aspect of the hand. The patient whose hands we can see perfectly illustrates the widening of the intermetacarpal spaces and complains about her too visible venous network as well as her too visible extensor tendons as her skin has become thinner and lost its elasticity. First, we have to assess the necessary quantity of fat to be injected. In this particular case, 10 cc per hand seems sufficient, the aim being to lift the skin by approximately 2 mm on a 7 cm by 7 cm area. The equipment required is a kit containing a 2 mm harvesting cannula, not 0.8 mm reinjection cannulas, and a fat transfer adapter. Some additional equipment is required, such as 14 gauge and 21 gauge needles. The very specific 8-hole harvesting cannula with an oval-shaped tip is also used as an infiltration cannula. Further injection, not 0.8 mm injection cannulas, are required, and the most commonly used are 40 mm in length. With microsampling cannulas, fat cells of approximately 600 microns can be harvested. The local anesthesia of the entry points of the harvesting area and ends is performed with 1% lidocaine with epinephrine. Fat is harvested on the abdomen or the internal region of the knees. Once the entry points have been anesthetized with a 30 gauge needle, puncture sites will be made with a 14 gauge needle. The infiltrated anesthetic product contains 60 cc of lidocaine with epinephrine and 80 cc of physiological serum. 30 cc were injected on each flank, 40 cc above the navel and 40 cc below the navel. The areas were immediately anesthetized. Harvesting can now start. Low pressure has to be applied. The plunger has to constantly touch the adipose tissue. Fat needs to be harvested repeatedly, approximately 30 times, to fill a 10 cc syringe. When 60 cc have been harvested, the adipose tissue is either decanted for 20 minutes or centrifuged at 3,000 revolutions per minute per 1,200 G for 2 minutes maximum to obtain a tissue fluid enough to allow reinjection. The lower part of the sample, containing the anesthetic product and blood, is eliminated. The upper oily part is always in small quantity, usually some drops. After centrifugation, 20 cc of adipose tissue is left. Fat is transferred to 1 mm Luolox syringes. To prevent air bubbles, the 10 cc syringe has first to be connected to the adapter, and fat is pushed out of the syringe to the edge of the adapter before being connected to the 1 cc syringe. The transfer can then start. The hands can now be grafted. The cartography of the areas to be grafted is performed. First, the venous network has to be studied to avoid it, either when puncturing or when moving the cannula. As many entry points as necessary have to be marked to get access to all the region of the dorsum of the hand without touching the major veins. Reinjection time is painless and only the puncture sites have to be anesthetized. Puncture sites are made from injection angle with a 21 gauge needle to go beyond epidermal and dermal layers. The fat is deposited in microtunnels in the very subcutaneous plane, approximately 20 to 30 microtunnels per cubic centimeters of fat are performed. The cannula has to be placed as superficially as possible above the venous plane. The distal extremity of the cannula is controlled with the contralateral hand. When re-injection is finished, the hand dorsa are massaged to correctly spread the adipose tissue. No dressing is required on the hands after the surgery. A total of 10 cc of fat was injected in each hand. We can see the patient's hands at the end of the procedure. It lasted 45 minutes and the patient is able to go home. She's asked not to apply pressure to the dorsal aspect of her hands for 1 week. 7 days after the procedure, no edema nor hematoma were observed during the follow-up visit. The next follow-up visits are scheduled 2 months and 6 months afterwards. After 6 months, the fat transfer trophic effect can be best assessed.